General Manager Quality Assurance. Ma'am, we will welcome you for this today's event.
Thank you, Sashi.
With this note, I hand over to you, ma'am, for your session.
Thank you, Sashi. First of all, I would like to thank ANTO and ISRT for giving me this opportunity to speak. Quality assurance and accreditations, I'm always happy to orient anybody on this. This has been my core area for the last at least 8 to 9 years. We as an organization, Columbia Asia, has multiple assessments, more than 30 assessments in the last 5 to 6 years. So being a part of all that, it's a great experience and great learning. Today, I'm going to orient you all on radiology or imaging applicable standards, both in NABH and JCI. I'll take you through how the standards are, what exactly accreditation means, what do they want us to do, and also how the each standard requirement is and what we have to do to comply. So I'll move on to the presentation now. Shashi, please tell me if my screen is visible.
Not yet, ma'am.
Not yet. So let me share again.
And sir, can you mute your mic?
Are you able to see now? Shashi, are you able to see my screen?
No, ma'am. I think you shared whole screen, I guess. Can you share a window through that, ma'am?
Yes, yes.
Now I think you shared your entire screen. Can you stop that and stop presenting and come back?
Visible now?
Yes, yes, yes. You can make it a full screen. Yes, it is visible. Thank you, ma'am.
Okay. Let us start with understanding what accreditation means and who are the providers and what are the basic expectations from these providers. To start with, we will be talking about NABH and JCI accreditation standards. We have chosen only these two because these are the most common accreditation, and one of it is the national accreditation and the other one is the well-known and the most common international accreditation, that is JCI. So before we actually jump into what the standards are and what we are supposed to do, let us try to understand why do we actually need accreditation and what does it help us with. For an organization, accreditation is actually a recognition and that it maintains certain set of standards. That means it is at already a different level as compared to any other ordinary organization. It is also a recognition by peers, that is both within or across the country, whichever way you see, inside the institution, definitely if your institution is accredited as an employee, you are much better off than another person working in another organization. And also across the country, when two institutions are compared, any institution with an accreditation has a better recognition. It stimulates continuous improvement. What does this mean? Accreditation is actually not just a certification or a recognition, but it is the initiation of a journey, that is a journey of continuous improvement. So we always say that once an organization gets accredited, its journey on continuous improvement starts. It raises or improves confidence among the community. How does this happen? So whenever a patient or anybody visits a hospital, they feel more confident because an accredited organization has all their standards that are set. It is more safer as compared to another organization. The last thing is improved clinical outcomes. Why do we say they are improved clinical outcomes? As a part of continuous improvement, it is not only the physical structure or it is not only the safety aspects, it is also the clinical aspects that are taken care of, and also even the clinical areas fall into continuous improvement. So automatically, there are better clinical outcomes in an accredited organization. Everybody must be thinking now, what is in for me in an accreditation organization? All that we heard until now was how good an organization is if it is accredited. But what is in it for me? Effective leadership. The leadership automatically is pushed to be more effective than an ordinary organization because there are a set of standards exclusively for the leadership which they have to follow in order to be accredited. These are like ensuring that each staff is educated well. They have staff welfare programs. They also have staff or feedback that is taken every year, and they improve upon the feedback. So there are a lot more things like that as a leadership which they have to follow if they're an accredited organization. Ownership of clinical processes. Be it the doctors, the nurses, or any other care providers like the radiographers or the lab technicians, whoever provides direct care to the patient, they have to have the ownership of these clinical processes, and this helps in betterment of the outcomes. Good working environment. Automatically, when you're accredited, the working environment becomes very safe because you have a set protocols that you need to follow. You have to comply to statutory requirements, and you also have to comply to a lot of audits, automatically converting the whole environment into a safe and a good working environment. When you're working in an environment like that, and there is continuous learning, which is a mandate if you are an accredited organization, the staff automatically becomes satisfied and more contented at work. So when you think what is in it for me as a part of accredited organization, all these fall into that gamut. Now let us move into who are these organizations who actually give us accreditation or accredit an organization. So there are two bodies which we are going to talk about today. One is the National Accreditation Board for Hospitals and Healthcare Providers. Most of you, I guess all of you must be knowing about this. And the other one is Joint Commission International. While NABH is the quality arm of Quality Council of India, exclusively for the hospitals, NABH manages. While Joint Commission International is the international arm of Joint Commission, which is the US-based accrediting organization. So what do these accreditation bodies have to tell us? Or what is the purpose of these accreditation bodies? They have a set of standards which focus on, NABH focuses on patient safety and quality of delivery of services. So what does this mean? The main area of focus is patient safety. That is, when a patient enters into the organization until the patient exits from the hospital, it is very safe for the patient. And the quality of delivery of services by the hospitals is changing the healthcare environment. There is continuous improvement in the quality of service that is being provided. And what does JCI have to say? JCI also says patient safety and quality of healthcare in international areas. That is their area of focus. So together, both NABH and JCI aim at or focus at only patient safety and improving quality of healthcare in the organizations. So let us see where actually all these details about patient safety and how to improve the healthcare quality is given. These are called as guidebooks. Guidebooks are more like the Bibles for NABH and JCI. What do these guidebooks have? NABH currently is in the 5th edition and JCI currently is in the 7th edition. Guidebooks are the books which actually have the details of what needs to be done by an organization to actually achieve this accreditation. So what needs to be done, how it needs to be done, and what all needs to be documented, everything is given in these guidebooks. Now, how are these guidebooks organized? How is the content in the guidebooks organized basically? Coming to NABH, NABH has 10 chapters. Each chapter is a set of standards, and these standards are applicable to a bunch of activities which are usually related to either patient's journey or a particular service or a department. So for example, NABH has 10 chapters. The first 5 chapters are applicable to patient care. The next 5 chapters are all management related. Patient care means, for example, the first chapter is access, assessment, and continuity of care. It is called AAC. That means, how is the access to the hospital? What is the assessment that is done on patients once they reach the hospital? And how is the continuity of care managed once the patient is admitted in the hospital? So these are the aspects. So it covers the patient journey right from entry till the patient gets admitted in the hospital. In the similar way, JCI has 14 chapters. JCI is a little more elaborate than NABH. It is a more prescriptive, and the number of standards and objective elements are also greater. This is because these standards are applicable across the whole world except for the US. This is the international arm of JCI, Joint Commission. So it's applicable to all across the world. That's why they are more elaborate and more prescriptive, so that it becomes easy for the organization to follow. So it has 14 chapters. It's been divided into 6 patient care related chapters, 6 management related chapters, and 2 additional chapters which are related to medical colleges or medical training programs, and the last chapter is based on research. So this is the structure of the chapters. Now, once we know the structure of the chapters, coming to imaging specifically, there is no full chapter that is dedicated to imaging. There is a portion of one of these chapters which is applicable to imaging. So it is very important for us to understand how this is, how the structure of these standards are. So for every chapter, there are a set of standards. So a chapter can have 10 standards, a chapter can have 20 standards, depends on what type of area it is covering. So what is a standard? Standard is basically a statement that defines the structures and processes that must be followed or that must be available in an organization. For example, standard says the organization needs to define the scope of services and display scope of services. That's all is a standard. Now, how do we understand what exactly the standard wants us to do? It says we need to define, and it also says we need to display. So the next part of it is objective element. Objective element actually says, how do I define the scope of services, and where do I display the scope of services? So an objective element exactly tells you how to do the standard or how to comply to a standard. So if it says the scope of services needs to be defined by the organization, it needs to be approved by the leadership of the organization. That's how the objective elements are designed. And if they say display, the objective element will say the scope of services needs to be displayed in a prominent area in the hospital. For example, the lobby. It also says the scope of services needs to be bilingual. That is, one in local language and one in English. So the objective elements basically tell you stepwise what needs to be done to comply to a standard. To add to this, there is something called interpretation, which actually describes the whole standard and how do you go about doing this entire thing. While the objective elements help you to score whether you're compliant or not compliant to a particular standard, interpretation will give you a complete guidance as to how do you go about implementing this standard. When we apply NABH or JCI to any of our organizations, when they come to audit us, they audit us on the objective elements. Basically, the scoring is done on the objective elements. The scoring is a little different between NABH and JCI. So NABH has the scoring system from 0 to 10, wherein there is a percentage of sample. If there is a compliance, you get 10 out of 10. If there is 80% compliance, you get 8 out of 10. So like that, from 0 to 10 is what they have graded it. Similarly, JCI also has the exact structure, just the objective elements name is changed into measurable elements for them. So when you say measurable elements, it's very clear that the scoring is done or you're measured for this particular standard based on these elements. And interpretation in turn is called intent. So this is how the structure of the standards or the chapters is organized in these guidebooks. So if NABH and JCI has given us guidebooks to understand what they want from us, how do we go about achieving it in our organization? It is very difficult for us to just read the guidebooks and say that, okay, we will go by doing this. As hospitals, the entire workflow and everything is very complex. So we need something that is called documentation. And this is considered as a first step to any accreditation program. We need to have our own documentation as an organization. So what are these documentations basically? Documentation is operation system documentation. We have just divided them for clarity. Operation system documentation, this means whatever you're doing on a daily basis and whatever you're doing as a part of objectives of your department, like if you're receiving a patient, if you're performing a particular investigation on a patient, if you're issuing reports to a patient, there is a certain methodology that you follow. These are the things that you are expected to document as either operations manuals or in the form of SOPs, standard operating procedures. Okay, why do we have to document these? So today, I, as a person in the organization, if I have to understand how one particular process runs, these manuals or these operating procedures form as guidelines. And if you have to repeat the same thing time and again, and if everybody has to do it the same way, these actually form the basis for it. These form the basis for reference, these form the basis for training, these also form the basis for standardization in your organization. So it is very important that you have these SOPs. The other documents are forms and formats. Forms and formats also help you maintain uniformity, especially when it comes to documents like consents or documents like safety checklists. You need to have standardized formats so that you don't miss out on anything and you do it correctly every time you do it. The second set of documentations are quality system documentation. So apart from doing your routine work every day, you also follow something called quality assurance. Quality assurance is mandatory as long as you're taking accreditation. As I said, it's the beginning of continuous improvement. So you have an assurance program. Assurance program is more related to auditing, how your department is performing. You have key performance indicators. For all your processes, you need to have performance indicators, which helps you monitor how your processes are running, whether they are running well, whether there are a lot of deviations, whether there are a lot of mistakes or incidents or accidents that are happening. Everything can be monitored using key performance indicators. You can set performance indicators, and that will help you monitor. Quality improvement programs. So based on your audit outcomes, based on how your performance indicators are behaving, you can always have quality improvement programs in your departments, which will help normalize the activities. This is the second set of documentation. Specialized documentation. While specialized documentation may not be applicable to all the departments in the hospital, definitely they are applicable to special areas like radiology, where safety is a key thing, and to other areas like facilities, where environment safety is a key thing. So in that way, safety documentation can be in the form of procedures, it can be in the form of audit checklists, it can be in the form of risk registers, which is a proactive approach of trying to identify what risks are there in your department and ensuring you have enough mitigation measures. Statutory reports, this is actually listing down what statutory reports you need to submit or what statutory compliances you need to have to run the department safely. So all these come as specialized documentation. The final part of documentation is, once you have all this documentation, it is not just enough with having the documentation, but you need to have control system for these documentation. Why do you need to have control on these documentation is, if you do not have control, you will have multiple versions floating around. You do not know whether you're following the latest one, or you do not know if there are any certain amendments in these documents. Are you following the amendments? Are you aware of it? Have you made any changes? No tracking will be there. So once you have documentation, the key element to it is document control. So you have 7 elements that I've listed down as a part of document control. You need to have all these elements monitored well to manage documents, updated documents for the availability of everybody. So each document needs to be named, you need to have an approver, you need to have date created, you need to have a version control on it so that you know this is the latest version and everybody has to access only this. Amendments and tracking changes need to be available in the document itself so that anybody accesses, they know that these changes have been made recently to the document. And you need to have a methodology of publishing them to your department. How do you publish? How do you tell them that this is the latest document? How do you tell them that we have released a new document? So all these things. And managing obsoleted documents. How do you actually remove obsolete documents from your system? That is also a very important thing. So this is about the documentation. Now let us move directly into the standards. As I told you in the beginning, I'm only talking about standards because there is no complete chapter that is applicable to NABH, applicable to imaging, both in NABH and JCI. Only a part of one chapter is applicable in both cases. So in detail, I will take you through NABH standards, and associated JCI standards I will run you through, because the intent of both these standards is exactly the same. It's just that NABH has 3 standards and JCI has elaborated these 3 standards itself into 6 sets. AOP 6 to AOP 6.6 is in JCI. In NABH, it is AAC 9 to AAC 11. As I told you, AAC is Access, Assessment and Continuity of Care. And in JCI, it is Assessment of Patient. NABH, this is the first chapter, AAC, and in JCI, this forms the 4th chapter. So let us directly move into what the standards are. The first one, AAC 9, the standard says, imaging services are provided as per the scope of services of the organization. So they are linking the imaging services to the scope of services of the hospital or the organization. So what are the measurable elements in this? Imaging services comply with legal requirements. What does this mean? The organization should be aware of the legal requirements. Everybody must be knowing radiology has a lot of legal requirements, right from the installation till performing and till reporting and till submitting reports to other authorities, health authorities. There are a lot of legal requirements for imaging services. So organizations should be aware of the legal requirements. You should comply with them. Department should ensure compliance. That means it is not just being aware, but you need to ensure that at every point in time you comply with all these. If you have to comply to AERB requirements, you need to have the compliance and you need to have the documentation to show it. You also need to have a monitoring mechanism. If there are certain licenses which have an expiry date or an expiry period, you need to have a mechanism to monitor when these are getting expired and when do you apply and how much in advance do you apply for these. Now, all these has to be in the form of a tracker or any other monitoring mechanism. Usually, all the organizations have a specific tracker. So all the radiology required or imaging required legal requirements should be a part of that tracker. Statutory requirements are met with AERB requirements. Like you also have these dosimeters, which you have to send them quarterly. You have lead shields requirements. You have specific signage requirements and displays as per PCPNDT guidelines. So many of them like that. And also availability of a radiation safety officer. These are the legal requirements pertaining to imaging services, and these are also pertaining to the whole organization. The scope of imaging services are commensurate with the services provided by the organization. So what does this mean? That the scope of imaging services is commensurate with the organization. So whatever services we are providing in the hospital, in the department, should be in consonance with the services that you're providing in the hospital. That is, if a hospital has neurosurgery and it frequently admits head injury cases, you need to understand that CT shall be available in-house. You cannot outsource that investigation for that particular investigation. So based on that, your services need to be in consonance with whatever the organization is providing to the people outside. And it is also good if you have all ER related services to be in-house so that your treatment doesn't get suffered if you have to outsource these particular investigations. Infrastructure and manpower is adequate to provide for its defined scope of services. So since you are providing services in-house for all those services, it is not only necessary that you agree to provide them, but you need to have adequate equipment and also manpower. So what does JCI have to say? JCI also says radiology and diagnostic imaging services are available to meet patient services, meet applicable local and national standards, laws and regulations. It is so much similar to what NABH is also saying. So it says services should meet local and national standards, laws and regulations. So it is all applicable statutory. Then needs related to hospital's mission and patient population. As we said, it should be in commensurate with the services being provided by the organization. It maintains a roster of experts in case you have specialized diagnostic services being provided. So NABH says the manpower should be adequate. JCI says you need to maintain a roster of experts. That, as I told you all, it is more elaborate. So JCI requires you to show the roster of all the doctors or staff that are actually being posted in your department. Then outside sources, just in case you are actually outsourcing the investigations, you need to actually be able to choose the outsourced organizations based on certain set of recommendations. So both JCI and NABH have similar requirement when it comes to the first standard. It also says adequately qualified and trained personnel perform, supervise, interpret the investigations. That means credentialing and privileging is essential for both radiologists and radiographers. Earlier it was only for radiologists, and now even the radiographers have been included. So you need to be sure that each and every staff working in your department needs to be credentialed and privileged. Credentials they come with, you need to be privileging them based on their experience. Documented policies and procedures exist to ensure correct identification, safe and timely transportation of patients. So patient identification, as you know, is the key thing, is one of these first international patient safety goals. It is also a WHO safety solution. So patient identification is key. Since you have outsourcing of investigations, you might have to transport patients outside the organization. Also, radiology department inpatients get transferred into the department. So shifting of stable and unstable patients and these transfers should be done very cautiously, and everybody in the department needs to be aware of. Safety while shifting to outsource centers is the key. If unstable patients are going, you need to understand very clearly who goes with the patient and who is responsible for patient care as long as the patient is in transit or is in the other organization. Last thing is imaging results are available within a defined time frame. I don't have to explain this much. Turnaround time. Turnaround time needs to be defined for routine, stat, off-duty hours, and holidays. And not only just defining the turnaround time, you also need to monitor how the turnaround time is being adhered to. And if there are any deviations, you need to have corrective and preventive actions taken. What does JCI say? JCI also says something similar. It says qualified individuals are responsible for managing radiology and diagnostic services. As we said, credentialing and privileging is the key thing. They also say that proper qualification and experience to perform diagnostic and imaging studies, that is the radiographers, and proper qualification and experience to interpret study results, that's for the radiologists. And they also say adequate number of staff should always be available to meet the patient needs. AOP 6.3 is also applicable to the same standard of NABH. It says that imaging study results are available in a timely way as defined by the hospital. So you need to have an expected report time for results. That's the TAT, what we commonly call. Timeliness of reporting of urgent, as I said, stat reporting or emergency studies needs to be actually defined. And these results should be within a time frame to meet patient needs. It should not be that we have defined, we will result. It is not enough that we just define a time frame, but we need to be cautious that they should help in actually meeting the patient needs. Like if it's stat and I say it is 3 hours reporting, it does not make any sense. And if it is routine, if I say that it is 3 days or 4 days for reporting, then also it does not make any sense. So we need to be very cautious when we are actually defining these timings. At the same time, we should have a mechanism for monitoring them. Sorry. Okay. Critical results are intimated immediately to the person concerned. So once the critical results, what are critical results? Critical results which the doctor needs to know immediately so that the patient care is not affected because we have not released the result. So as a department, you need to have the list of all these critical results displayed in the department, and everybody should be trained. And these results should be intimated to the treating team immediately. So you can define a maximum of 1 hour and not beyond that for intimating these. And this shall be documented. Whenever you intimate a result, it should be documented. Name of the person, ID, investigation, the result, and the name of the person who has received the investigation result should be actually documented. And finally, there should also be a readback so that the person who has received the result confirms that they have received the right result for the right patient. Results are reported in a standardized manner. That means every time you release a report, it needs to be structured. It needs to have certain content to it and definitive content to it. So that's all which is required. And I understand that all the organizations have this. This should not be a problem. There is a mechanism to address recall of or amendment of reports whenever applicable. So whenever there are changes to a report, because of errors, or if you want to add on additional things to your report, there should be a method where you can recall the report. Recalling is you need to bring back the report from wherever it has been issued to. If it is issued in the HMIS to the doctors, that is, if it's present for them to view, you should be able to withdraw a report. If you have issued it to the patient physically, you should be able to call the patient and ask the patient to return or do not consider that report and immediately release the edited report. And whenever such amendments are done, a root cause analysis needs to be done, why there is an amendment to the report or why there is an error in this reporting, and immediately corrective and preventive actions should be instilled. Imaging tests that are not available in the organization are outsourced to other organizations. This we have already spoken about. You need to have a set of standards that you need to follow when you're choosing an outsourced organization. A written SOP is very important, and a memorandum of understanding or a contract which is valid should always be there. You should always have an identity of a person whom you can contact in case you need to know anything about that, about a patient who's transferred, about a report or anything. You need to definitely have the identity of a contact person. Coming to the next standard, AAC 10, it says there is an established quality assurance program for imaging services. So for the quality assurance program, what all includes in imaging services? Equipment related, you need to have safety related programs, you need to have audits, you need to have statutory monitoring, which we discussed earlier. And we need to, when we do all this and we monitor, if we find some deviations or if we find some accidents or incidents happening, we need to have a documented root cause analysis and corrective and preventive actions. Quality assurance programs in radiology specifically includes tests for imaging equipment. That is, there are a set of tests, the technical part of it, which the RSO is responsible. You need to have a set of tests that are done. And periodic testing of the safety equipment also has to be done, like the lead aprons or any other shields. You have an annual checkup of them. All those form a part of the quality assurance program. Quality assurance program includes review of imaging protocols. Now, these protocols should be in consonance with the clinical requirement. So for adults, you might have some protocols, and for the same investigation for the pediatric patients, you might have something different. Measuring and monitoring dosage received by the patient. As I said, these protocols and also the dosage received by these patients should be monitored. Currently, some hospitals do monitor and some hospitals do not have the capability of monitoring, but it is best advised that you monitor the dosage received by these patients so that they do not exceed whatever is actually permissible. The last one is a system is in place to ensure appropriateness of investigations and procedures for clinical indication. When any investigation is actually recommended for a patient, before performing the investigation, you need to have a screening mechanism. So based on the requisition received and the clinical history and the presentation of the patient, you need to be able to justify, the radiologist should be able to justify whether this investigation is appropriate for the patient or not. This can be simply done by incorporating the part in your radiology requisition itself, where the radiologist can see it and sign it off. For example, if mammogram is prescribed for a patient who is a lactating mother of 25 years old or 28 years old, it is not apt for that particular patient. So you need to have a screening mechanism where you actually say what is applicable, what is appropriate, and what is not appropriate. The same thing is applicable even in JCI. AOP 6.5, quality control procedures are in place, followed, validated, and documented. So this includes validating the test methods, and regular surveillance and documentation of imaging results also needs to be done. And when you see deviations, there should be rapid correction and documentation whenever there is a deficiency identified. There is a program that addresses periodic internal and external peer review of imaging results using appropriate sample. So NABH recommends that you do this at least for CTA and MRI, and at least 1% of the sample should be taken. Peer review can be done by either the head of the department, or you can also have fellow radiologists review the other radiologists' reports and then issue the result. If there are any deviations to this, corrective and preventive action should be instilled immediately. And the program addresses clinico-radiological meetings. This is something very new that has been introduced in the 5th edition of NABH. This is, you need to have meetings with the referring physicians on the quality of imaging and reporting to see the satisfaction levels, or to see if you have to improve upon anything, or if they have any other recommendations. These meetings can be quarterly basis or half yearly basis. Usually, most of the organizations have tumor boards. These are the specific clinical radiological meetings, but it is not adequate that you have it only with the oncology team. You also need to have with all other specialities who are referring cases to radiology. So you can have it on a quarterly basis, you can have it on a half yearly basis, you can discuss the quality of the images, or you can also discuss the KPIs. The program includes periodic calibration and maintenance of the equipment. I need not elaborate on this. Every organization needs to have a PM schedule for all the equipment. And you always have to monitor whether you're adhering to the schedule and you're completing your maintenance, you're maintaining the documents pertaining to these schedules or not. The program includes documentation of corrective and preventive actions. The same thing exactly, whatever NABH says, AOP 6.6 of JCI. It also says quality control data from outside contracted sources. You need to have an eye on other outsourced organizations if you are having. A qualified designee reviews the quality control results of the outside organization also, which NABH only says that you need to assure that you are outsourcing investigation to a good organization. Annual report of quality control data from the outsourced contract source is also monitored according to JCI. It also says that they develop and implement and document a program, quality assurance program, and equipment maintenance program. You need to have a methodology to select new equipment, and equipment is inspected and tested when new and according to age. That is, it's a part of the maintenance. Calibration and maintenance need to be managed. And also, if there are any recalls or reportable incidents, you need to have a mechanism. How will you manage the recall of a particular equipment? Finally, the radiation safety program. So every organization needs to have a radiation safety program. This needs to be implemented. It has to be in consonance with AERB. Follow certain principles like ALARA, and this basically modifies CT protocols to ensure lowest exposure. This is something that everybody needs to follow, and this is what we have seen in our organization also. We do not do, and we do not monitor the dosage received by the patients. So we need to do this. The program needs to be aligned with the organization safety program. That means radiation safety program should not be running separately, but it should be along with the whole hospital's program. That means any other place in the hospital uses the equipment or staff who are exposed should all be covered under this radiation program, like the cath lab, OT, anywhere else. Patients are appropriately screened for safety and risk before imaging, like pregnancy screening, MRI screening, etc. needs to be done. Then imaging personnel and patients use appropriate radiation safety and monitoring devices where applicable. That is, you need to have appropriate PPE, and you also need to ensure that the TLG badges are issued and monitored quarterly. Then there is a radiation safety and monitoring devices are periodically tested. As we mentioned earlier, screening of all these equipment PPE needs to happen, and quarterly TLD badges need to be sent for readings. Then the imaging and safety personnel are trained. It's not just that you provide everything to them, but you also need to train them, not only in the radiation safety, but also in other patient safety things like patient falls, etc. Then imaging signage is prominently displayed in all appropriate locations. This should be absolutely in consonance with the statutory and safety guidelines, like the PCPNDT or the ARB guidelines. You need to display all the signages across the hospitals. The same thing with JCI. Imaging and safety program for patients, staff, and visitors should be there. Staff should be oriented to all safety precautions. Protective equipment and devices should be appropriate and be available all the time. Education about dosing and implementation of protocols should be clear and should be oriented to the staff. You need to have clear identification of safety zones, access restrictions, and signages. And the safety program should be a part of the organization's facility safety program. So that ends the standards part of it. The last bit is, how do you prepare for your assessment? We actually start off doing a gap analysis. What is a gap analysis? You have a set of standards given in the guidebooks of both NABH and JCI. You just take the standards and just measure what is there in your hospital in the form of a document or in the form of an implementation or a signage or anything. You list down the gaps that are there based on the standards. Once you list down the gaps, you have a to-do list. You start training your teams on your gaps and simultaneously start closing the gaps. Once you feel you have satisfactorily closed the gaps, you audit, you conduct an internal audit. An internal audit should always be conducted by somebody outside the department so that it is unbiased. And once you conduct an audit and you're satisfied with the results, you can say that you are ready for the assessment. So this is the basic preparation and how you focus on preparing for accreditation. So that brings us to an end of this particular presentation. And thank you. I'll be okay to take any questions if there are.
Thank you so much, ma'am. We had a few questions in the chat box and as well as in the YouTube. The first question is, which is the latest NABH standard and any addition in indicators?
Okay, NABH latest standards set guidebook is 5th edition, and indicators. So in the guidebook, if you go to the last section in the guidebook, it has a separate section called the annexures, and the last annexure is on the KPIs, key performance indicators. There are only 2 KPIs as of now for NABH, as per NABH. One is reporting errors by radiology, monitoring reporting errors. The second one is on safety, adherence to safety precautions by the employees. These are the 2 KPIs. So if you look at the last section of the guidebook, you will find the KPIs there.
Okay, the next question, ma'am, the NABH or JCA, which is good?
See, accreditation, both are good. Like when we saw the standards, they are neck to neck. It is just that JCI is more prescriptive, and it will tell you to do in a specific and a defined way, whereas NABH will tell you to do it, and it will give you the little bit of liberty to do it on your own based on the health system in India. But both the standards are equally stringent because both of them are particular about statutory, both of them are particular about safety, and worldwide safety is the same when it comes to imaging and radiology. So both are equally good.
Okay, ma'am. Okay. The next 2 more questions. In that one question, how many years we need to get NABH and as well as for the JCI?
It is not the number of years, actually. It's based on your preparation. So it is, you need to actually show at least 3 months of implementation of NABH standards to NABH to ask them to come for an assessment or to apply. So it can be any time from the day you start your organization. So 3 months from then, when you feel that you are ready and you feel your gaps are closed after you do an internal audit, you can apply for NABH. JCI also similarly, JCI, but it expects at least 18 months it takes for you to prepare and comply to their particular standards. So JCI takes a little longer, but both of them do not prescribe anything. NABH just says 3 months, to show that past 3 months we've been actually complying to NABH standards. And JCI says past 1 year, you need to be able to show that you are actually complying to their standards. That's all.
Okay, ma'am. Your camera can be on, ma'am?
Just a second.
maybe since the live session,
Okay.
so you'll be answering questions, but
Got
the
it.
last question, ma'am, regarding radiographer credential template in NABH.
Okay, there is no template as such. Credentialing is whatever qualifications they're having. Privileging, definitely there will be a template, but it depends on the organization. You can make your own template. Like if you have 4 or 5 modalities in your particular department, you can actually prepare, like if this particular technician has done 50 procedures independently for this particular modality, then he is privileged to do so and so independently, like that. Privileging and credentialing is actually dependent on the organization. But basically, credentialing is nothing but their qualification, but privileging is mostly by the organization, how they are allowing their staff to perform tasks independently.
I think one more question. Is NABH and MIS is difficult?
Not really. I don't think so. Any of these accreditations are difficult. It is about your commitment. That's all. If you decide to do it, it will happen. Nothing is difficult. It's about organizing yourself and disciplining your team. That's it. It is not at all difficult.
Okay, okay. That's all questions from the audience, from the YouTube, as well as from the chat box, ma'am. Thank you so much for accepting our invitation, and you agreed to be. I know that it's a Sunday. We had a long session even last week also, and I hope that today's session is wonderful. I mean, it definitely is helpful for all our radiology fraternity. And thank you so much, ma'am, for accepting our invitation, and you've given a wonderful presentation. With this, I will end today's guest talk. We can go ahead with the next oral presentation. I think Anto sir like to say any words. Can you unmute, sir? Anto sir, you.
Shashi, am I audible?
Yes, yes.
Yeah. Thank you, Dr. Sri Lakshmi, for your time, and Shashi for coordinating, and thank you all. And welcome Rajiv and Dr. Dhananjay. If you have any questions, please.
Thank you, ma'am, for your excellent presentation. I would like to ask very pertinent question. Is there any cost impact to have a NABH? Because most of diagnostic independent centers are worrying about the financial impact initially and as well as long term. So, how to be cost effective NABH accreditation for any small centers, so that quality should be improved and that will not much impacting on financial aspects of any facility.
So NABH, be it NABH or JCI, they do have a certain fee. That is the application fee and the annual fee that you need to be paying, and also of assessors visiting and doing. To be simple, if you really don't want to actually get into that, and if you feel that it is too costly, it is not difficult that you buy a set of standards and start complying it on your own. So that is the easiest way if you say that you don't want to actually invest in that kind of money doing NABH and the certification part of it. But I guess it is definitely helpful, because if you're a diagnostic center, nearby hospitals or anybody can refer cases easily based on what your NABH, I mean, based on your certification. So that will be definitely an advantage for you, if you see. And you need to be really strict and disciplined to manage all this without somebody coming from outside and auditing you and all. So that's the advantage you get, that NABH is going to come and you are forced to monitor, you're forced to comply to certain things. So that's definitely an advantage if you have them come and accredit you. Otherwise, the simplest way is you buy the set of standards, you know what needs to be done, and you comply to it.
Right. Thank you.
Okay.
Shashi, you have to mute.
Thank you so much, ma'am, for answering all the questions, and thank you for your time spending with us. We'll move ahead with the next session. That is oral presentation for the staff. Today we have judges from different part of our country. We have Dr. Dhananjay Kumar Singh, assistant professor in Dr. Ram Manohar Lohia Institute of Medical Science, Lucknow. And also we have a Rajiv Krishnan, is a chief operations officers and marketing head in Cloudex Healthcare Private Limited, Cochin. And also we have a Partha Jyoti Das, the radiographer from IGM Hospital, Agartal, Tripura. And we have one more judge, Pragati Sahu, radiology technologist, National Cancer Institute, Nagpur. And I welcome all the judges as well as the oral presenter. We will go ahead with the first oral presenter today in a staff category, the Pradeep Singh Negi. I request Pradeep Singh Negi to upload your PowerPoint presentation. He's working in Pet Shoot Apollo Hospital, Delhi, and he's going to talk about improving TLG value by using MRI tumor volume in breast, PET, and MRI. Can you share your PPT, sir?
You have to unmute, Pradeep.
Can you unmute first? Yeah.
Is it okay?
Yes, yes. Can you share your this thing? You go to present now.
Yeah. Am I audible? And is it?
Yes, yes. You are audible.
Yes, you are.
Very good afternoon to all.
Share your PPT, sir.
Share your PPT.
It's already shared.
Not visible.
It's not visible, but one more times. Stop sharing. Let me again try. Present now.
A window. Go to a window.
Yeah. It's presented. A window. It's not. Is it okay?
Yeah. Can you go to
Yes.
full slide? Judges, please note, all of you, the oral presentation category, there is a 10 minutes time limit. If it is they cross the time limit, I will give a buzzer sound from my side. There might be a minus mark for that.
Very good afternoon to all judges and presentees and attendees. My topic is simultaneous PET MRI improving TLG value by using MRI tumor volume in breast cancer and breast PET MRI. The purpose of the study to modify TLG value by using simultaneous PET MRI system. The purpose is MTV to be calculated by applying set thresholds, identify threshold feature from the contrast enhanced MRI, create handcraft MRI base volume in breast cancer patient to improve MTV, use MRI based MTV to get modified TLG, and combine and analyze patient data to see treatment response in the breast cancer diagnosis. The purpose of the PET, choosing the PET MRI, because it's a simultaneous PET MRI, we can acquire PET and MR together in the in a breast cancer, the patient should have to lie down on tummy or prone position. So we can easily identify the small lesions in the MRI, and then we can correlate with the PET. This is the example how the MTV changes with the different thresholds. This is post-contrast MR images, and this is threshold with the different thresholds. The MTV is changing accordingly, according to the threshold. In 10% it is 40, and 20% is 19, and 30% is 8.484 and threshold, and it's changing to the we have calculated with the 50th, it's 3.71. The MTV has changed from 40 to 3.71. The same patient preparation for the PET MRI we have used as like PET CT, except that before the patient appointment and injection check the MR compatibility, like the patient should not have pacemaker and any metallic implant, which can affect the investigations. Patient should be fasted for 6 hours before the FDG administration. Blood glucose level should be less than 150 mg per dl. FDG intravenous injection 10 mg around, and PET were acquired after 60 minutes of the FDG injection, and breast PET and DC MRI, dynamic contrast enhanced MRI, were acquired immediate after the whole body. First, we are acquiring the whole body PET MRI, then we are acquiring the breast PET MRI. Why PET MRI? Because the PET MRI is superior soft tissue contrast resolution and dynamic contrast enhanced MRI, and PET is possible at one time before losing any other times. MRI is highly sensitive to detect small and more breast lesion as compared to the PET CT or CT. The PET and MRI acquired simultaneously, possibly to identify small breast lesion in the PET calculated MR based MTV. The material methods, we have taken 10 patients, female breast cancers, all are IDC, IDCs. Mean age was 57 plus minus 13. 8 were post-menopausal, 2 were pre-menopausal. Data were acquired in biograph MMR and evaluated in Syngovia Siemens workstations. TLG were calculated with this formula, TLG equal to MTV threshold into SUV mean. This is the work has been done in 2012 by Korean in Korean universities, Korean Society of Nuclear Medicines. They had done same work, but they had acquired a software that is called VCAR, and they automatically drawing the ROI and contouring the tumor and calculate the threshold values. And they had compared with it. They had done for response evaluation, and they found MTV and TLG reduction rates show significant correlation with the tumor size reduction rate. This is my work. We have calculated threshold with 20, 30, 40, 50, 60, 70, and 80%. And we see and we have calculated TLG with the help of MRI tumor volume. And we found that 20% is 20% threshold is comparable with the MRI volume. But if we see visually see the modified TLG modified volume and 20% volume are slightly different, then we have changed the modified threshold 30 to 9%. It's moving around, and then we found that MR volume are matching with the modified TLG value, and the p value are quite good when we compare with the modified volume and PET MR volumes. This is the example. We have calculated modified TLG value with 20% to 80% and modified TLG value, and then we found a good correlation with the MRI. This is an example for post-treatment and pre-treatment. This is basically, this work has been done for response evaluation. So we have done only one patient for response evaluation, and this is the values we found that MRT1 before NACT and after NACT, the volume has reduced 10 cc to 6.588 cc. But the threshold value we cannot fix as per the standard 50%, 50% or 30%. Then we compare with the MRI, the threshold value were 26% to 9 in pre-treatment, and it was 29%. It's significantly changing the T1 values. The summary of this this work: DCMR dynamic contrast enhanced breast MRI may be useful to modify MTV by using simultaneous PET MRI, and modify TLG value with the help of MR tumor volume in the breast cancer may be useful parameter for response evaluation. This is all. Thank you very much. We are finishing within the time. Is it any question?
I request Pradeep Negi sir to stop sharing. I hope there is no questions from the judges, I guess.
I think Dhananjay sir having some questions.
Thank you for your nice presentation. What is the impact of TLG value in this management?
The TLG value, TLG value definitely have some impact in the response evaluations. Once the patient came for with the breast cancers, and after NACT, the tumor volume doesn't move, doesn't sink, and the TLG value is come down. It means it's responding with the NACTs. It's impacting the patient treatment planning.
Okay. Can I ask second question?
Yes, sir.
What is the impact if we'll acquire a sequential PET MRI?
Sequential PET MRI, not simultaneous. Once we acquire the sequential PET MRI, both MR and PET will be different time of frames. Small lesion, we can sometimes small lesions of the breast lesion cannot be coated with PET, and sometimes the breast is very it's a very soft tissue. It's very soft and soft, only soft tissue. It positional difference may be occurred, and we cannot get the accurate MTV.
Okay.
Same works, BCAR method they have done in 2000, done sequence where they have done MRI and PET. Both are in other times, but they are doing it simultaneously.
Okay. Okay. Thank you.
Thank you, sir. Next, we'll go ahead with the next presenter. We have next presenter from the Sri Harita from Savita College of Allied Health Sciences, Chennai. I request you to upload your PowerPoint presentation. She's going to talk about comprehensive analysis of multiple myeloma in the field of diagnostic radiology.
So my screen is visible, sir?
Not yet, madam. Can you try once again?
Yes, sir. I'm trying. Okay, sir.
It is visible.
It's visible now, sir?
Yes, yes. Your time starts now. Go ahead, ma'am.
A very good evening to everyone. I'm Sri Harita, teaching faculty in SCHS. Today in this session, we are going to have a brief discussion about comprehensive analysis of multiple myeloma in the field of diagnostic radiology. Multiple myeloma is a cancer to a type of white blood cells called plasma cells. Usually what happens is like the plasma cells will fight against the infection by producing antibodies. But in case of multiple myeloma, these cancer cells will accumulate in your bone marrow and crowd out the healthy blood cells and results in production of abnormal proteins. This will cause complications and this is termed as Curler's disease. And the common signs and symptoms include joint pain, confused mind, fatigue, loss of appetite, excessive thirst, constipation, numbness, and weight loss. And in case of multiple myeloma, the common investigations are like complete blood count test, burn test, RFT test. So in case of multiple myeloma, we could be able to appreciate anemia, hypoglycemia, globulin cap, in which the gamma protein level will be elevated and the kidney diseases will be appreciated. If the symptoms and the findings are there, then we could be able to perform a bone marrow biopsy, in which a needle is introduced into your hip joint and the bone marrow and blood samples are collected and they are sent for further investigation. And the staging of multiple myeloma, it is based on the serum calcium level, amount of HB present, and it is based on the number of lytic lesions present. And these are the common stagings. And the distribution of multiple myeloma, it is mostly distributed to your axial skeletal and proximal appendicular skeletal. So the most common sites are like spine, your rib cage, your pelvis, your shoulder girdle, your skull, and the long bones. So the role of diagnostic radiology is like initial staging, detection, characterization of multiple myeloma, and it could be able to assess the mechanical complications like pathological fractures, and we could also be able to assess the prognosis of the disease. And the imaging modalities are like X-ray, CT, MRI, and nuclear medicine. So this is the imaging pathway for multiple myeloma. So first, in radiological features are like there are two radiological features. First thing is like the presence of bone lesions. Here you could be able to appreciate some lesions. It appears like a raindrop and therefore it is termed as skull, raindrop skull. And the next is like endoscale scalping. So it is a condition in which the inner marrow it will get eroded. So it will appear with a thickened appearance. And the next condition is osteopenia. It is very less common. In this condition, what happens is like the bone mineral density will be get reduced and it might result in fracture. So the imaging techniques first primarily involve your skeletal survey. So these are the views which we will perform. And the application are like plasmacytopenia and the myelomatosis and the diffuse osteopenia, compression fractures and sclerosing myeloma. And this is plain radiography with light lesions. And the advantages are like we could be able to appreciate cortical bone lesions. It is available universally and cost efficiency. And the disadvantages are like false negative rates are very high, prolonged study is done, and varying positions of the patients are required. And moving on to the next modality, it is CT, in which less than 5% of trabecular bone dissections could also be detected. The scan time is 40 to 60 seconds. And the applications are similar to that of skeletal survey. And this is a CT image of pelvis. Here we could be able to appreciate some cortical dissections in the left iliac bone. And punch-out lesions could also be detected in CT. It is a volume rendered image. We could be able to appreciate the lytic lesions. And it is an abdominal window. We could be able to appreciate the lytic lesions. And the advantages with CT is like extramedullary lesions could also be detected and it is less expensive. Low dose protocols are also available, but the disadvantages like it is similar to skeletal survey. And the next modality is MRI. It is better for evaluating the bone marrow and the scan time is 45 minutes. The applications are like we could be able to detect focal and bone lesion involvements and focal lesions could be detected. Bone marrow and spinal cord could be well appreciated and we could be able to differentiate whether it is a neoplasm and osteoporosis. And the common sequences are like T1 SAJ in which it will lesions will appear with a low signal intensity. And next is T2 stir Sag, in which it will appear with a high signal intensity. And there is a condition in which the infiltrations will be there. It will appear with a bright signal and it is termed as white rip sign. And the next is like diffusion sequence. In diffusion, we'll look for the cellularity of the region of interest. In case of lesion, it will have a low restriction. And the next sequence is like contrast enhanced MRI sequence. It will appear with a hyper signal intensity. And based on the perfusion and vascularity, we could have different curves. So this one is a T1 weighted SAT sequence image. We could be able to appreciate hypointensity area, that is myelomatous lesions. And this is T2 stiff SAG sequence. Same areas are appearing hyper. And the advantage is like we could be excellently correlate with survival outcome and no radiation dosage is used. And the disadvantage is like scan time is very increased and it's like costly, and it is contraindicated for patients with claustrophobia and metal implants. And the next procedure is CT guided biopsy. After following with the MRI, we'll perform CT guided biopsy. And the biopsy sites are like thoracic, lumbar, and bony pelvis regions, in which we'll introduce a bone biopsy needle. And the plasma cells and bloods are collected and are sent for microbiology department. And here it is a still coronal image. We could be able to appreciate a lesion in the light sacral ala. For the same patient, CT guided biopsy was performed. Next modality of choice is nuclear medicine, in which we could perform bone scintigraphy or PET CT. In bone to scintigraphy, we could be able to detect the bone involvement, in which technetium 99M is administered. And the next is like PET CT. It is mostly used, and with it we could be able to detect the activity of the tumor cells. We could be able to administrate FTG, and the scan time is like 80 to 90 minutes. Based on the distribution of FTG, we could be able to differentiate whether it is a benign or malignant cell. And the FOV covered is like from skull to femora, including your upper limb. So moving on to the case studies. Here it is a plain radiography. We could be able to detect some mass-like structure in it. So the patient was preferred to do MRI study, in which we could be able to appreciate cortical destructions and extracorticular extension. And this is a whole body CT done for a patient, in which we could be able to appreciate a non-lytic lesions, but it is not visualized in the bone window, it is visualized in soft tissue window. So MRI was performed. So this is T1 coronal sequence, and this is diffusion accurate sequence, and non-lytic lesions are well appreciated in it. And it is a reformatted colored image, and it is an inverted image, and it is a diffusion image. Here we could be able to see lesions in the clavicular region, and multiple myeloma was confirmed. And moving on to the conclusion, advances in imaging and therapeutic option results in improved survival of patient with multiple myeloma. It is not possible with single imaging modality to evaluate multiple myeloma, hence a combination of modalities are used, and it acts as a gold standard and better diagnosis and treatment, evaluation and prognosis of multiple myeloma. And these are some of my references. And thank you guys.
Yeah, over to judges. Dhananjay sir, any question? You can present your
Yeah. Thank you for a nice overview regarding the modality that all involve in better management of multiple myeloma. Could you tell me about the what is your understanding in what is the difference between bone scintigraphy and PET CT? You have mentioned these two modality.
Yes,
Have you any understanding? Yeah.
Bone scintigraphy was before, in olden days we had done it, sir. It's like we'll administer technetium 99M generator, that is generated product. But nowadays we are using FTG with in which annulation process are used, and we could be able to detect like in case of tumor cells and all, the accumulation of FTG it will be less, but in case of normal cells it will be more, sir. So based on that we could be
So
able to differentiate
okay,
it.
okay. So these two different tracer you are telling that need to be injected for different imaging.
Yes, sir.
Is there require a same machine or different kind of machine for these two imaging?
So PET will use a different machine, sir.
Okay, okay. Thank you.
Thank you, sir.
Thank you so much. I hope that there is no any more question. I will move ahead with the next presenter. Just please note that the next presenter is Mr. Sanjay Kumar. He's from working in Group Jeevan Hospital from the Chhattisgarh. He's going to talk about CT protocol for abdomen and pelvis. I request Sanjay Kumar, can you unmute and upload your PPT. Can you unmute? Sanjay Kumar, can you unmute? Can you hear Sanjay? I will join in a second. Kindly bear with me. संजय जी अनम्यूट कीजिए एंड स्टार्ट प्रेजेंटेशन स्टार्ट कीजिए. आप सुन रहे हैं आप? कैन यू अनम्यूट प्लीज? आपका वॉइस नहीं आ रहा है. The next competition is quiz competition. Please note that all the judges, it will take 30 minutes. Kindly take a break in between. After that, it will start the e-poster presentation. The quiz presentation, which is going to have the live for the state of Karnataka. Already we have received 105 colleges for the quiz competition. It was a wonderful response from the all over India, and we had prepared very well. And other than Karnataka, all state level competition we had already completed before 3 p.m. And now, since the quiz competition, we're going to have the live session for the quiz for the Karnataka state as a inaugural of the event. And judges, please kindly note that the another participant, Mr. Javid Rasul Bhatt, Due to the internet issue, he's from the government sub-district hospital, Srinagar. He is not able to join the today's competition. Kindly note that. Before that, anyway, I think if Sanjay joined, we will do it later, sir. We will go ahead since 4:30. I had announced the quiz program going to be conducted. All the dear participant for the quiz, please note that the guideline is clearly given in the email. There will be a link activates exactly at 4:30 p.m. Kindly note that it is exactly now 4:27. Within 3 minutes, the link will get activated. I request all the participants from the Karnataka. There are nearly around 9 colleges have registered for the from the Karnataka state. I request everyone to go to that link, visit that link, and the link will exactly activates at 4:30 p.m. at the round 1. In the round 1, there will be a MCQ questions with a 20 number of MCQ questions, and 15 minutes will be given to answer all the questions. 15 minutes will be given to answer all the questions. You need to enter all the details. Anyway, I'm going to display that all the questions which is going to be given to the Karnataka state once the time starts. Another 1 more minute. This is a great opportunity for all the participants since this is a different kind of novel initiative by the ISRT. There were a lot of other competition was held in the other event like e-push or oral presentation and all, but this kind of event which is it is the live quiz, it is happening first time, I guess. The time started already. I request everyone to refresh your link which is provided in the email and kindly start answering. So these are the detail. You need to enter all the email address and your name, your college name, and representative of the state. With this, thank you. The round one time is up. I hope that all of you submitted your answer before time end. We will have the next round. I hope that all of you are ready with the next round. We will start. We will not wait for the another 5 minutes. The next round will have 10 minutes only. Please note that. Round two, which is with the true and false question. There will be 25 questions. You will receive 10 minutes time only. So you need to answer within the 10 minutes. Within the 10 minutes. I hope that all of you ready. Please visit to the second link which is provided in the email. Go to the second link. Kindly wait. That will activate in another 20 seconds. Yes, that link is activated. Exactly at 4:55, the link will get end. Before that, you please submit your answer. The link is activated. Dear participant, another 30 seconds. This round 2 will get end and in another 30 seconds. Hope all of you have submitted your answers. Yeah, the time is end now. The result will be announced at the end of today's session after the poster. All of you can watch live later. I'll share it in the during a live session, and also it will be shared in the group which is created quiz group. Thank you so much for all the participant, particularly quiz. I request all the quiz participant to exit the this Google Meet link, and you can watch through the YouTube ISRT YouTube channel which is provided. It already shared that link along with you in the group. Thank you so much, and we'll move ahead with the today's e-poster presentation. We had a continuous e-poster presentation since last 3 weeks. Today is the last e-poster presentation in the topic of magnetic resonance imaging. Today is the first presenter is Alvin from Nimans, Bangalore. Alvin, I request you to upload your e-poster. Judges, please note, he is going to talk about amide proton transfer imaging, novel tumor imaging technique. There will be a 5 minutes given to him. The total time is given to him is 5 minutes. If it is across the time limit, I will give a the buzzer sound from my side. Alvin Pinto. Sorry, Alvin Anto.
Hello, sir. Am I
Yeah.
audible?
Yes, yes. Can you share your e-poster? It's not visible.
Yes, sir. Sir, is it visible, sir?
Yes.
Shall I start, sir?
Can you make it in the angle, the
Yes,
width
sir.
angle? And
Yes,
slowly
sir.
you can move. Since you are presenting through the mobile, the image is very small.
Is it okay, sir?
Yes, yes, fine. Yeah, your time starts now.
Okay. So, good evening to everyone. Myself, Alvin Anto. I am BSc Radiography internship student from NIMANS, Bangalore. So, I'll be presenting on the topic amide proton transfer imaging, that is novel tumor imaging technique. The objective of my presentation is that to create awareness about the APT weighted sequence where we can use in a tumor protocol. Introduction. APT weighted imaging is sensitive to the concentration of amide protons which contain in proteins and peptides, which are known to be elevated in high-grade gliomas and in recurring tumors. The basic principle behind the APT is that it's based on the principle of CEST. CEST is nothing but the chemical exchange saturation transfer. The most of the compounds analyzed in the CEST experiment are located on the left side of the graph, which is marked as positive frequency in relation to the water. In figure 1, as we can see, there are proteins and another is the water. As we know, in our body, there is around 60 to 70% of water. So water gives a high signal in MRI. So when we suppress the water, we use test experiment, that is chemical exchange saturation transfer. We apply an off-resonance MR pulse with a specific frequency of 3.5 ppm, such that we can suppress the protons of the amide protons, and we can suppress the water protons, and we can get the signal from the amide protons. And in figure 1, as we can see in the left side of the graph, it is the test effect which is known as APT, that is amide proton transfer, or it can be seen around 3.5 ppm, and at 3.5 ppm we can see the MTR asymmetric, that is magnetization transfer ratio asymmetric. And in right side of the graph, that is known as nuclear Obersauer effect, that is NOE. NOE effect is seen on the compounds such as aliphatic compounds and the lipids. And the pulse sequence. First, there are 3 ingredients in the pulse sequence, like we have to think in that way. The first is the patient adaptive multi-transmit OD, which delivers long and continuous RF saturation. That is almost around 2 seconds for optimal APT weighted contrast. Why we are giving continuous RF saturation? Because we need to suppress the water signal. Second is that is the sequence which is used. M is the multi-point exon, XD-TSC. TSC is the turbospin echo sequence, which enables an integrated B0 map for accurate and fast data acquisition. Third, conference. Clinical applications. There is a close relationship between the proliferative activity of the tumor and mobile protein synthesis. Tumor tissue contains an increased concentration of cytosolic proteins, which contribute to the APT signal. Following cases are done in Philips Engineer 3D MRI in NIMANS Institute. And there are several cases which are shown. Let us discuss one by one. First, clinical application is the prediction of malignancy gradient diffuse glioma. In figure 2, as we can see, in tissue-weighted image, there is an higher intensity signal, and in diffusion, we can see the ADC signal. In APT-weighted imaging, which is gives a high signal in the malignancy grade glioma, that is high APT signal. Another is the prediction of genetic mutation in gliomas. That is, there is 2 types of genetic mutation, that is IDH mutant and IDH wild type. IDH is nothing but isocitrate dehydrogenase gene. The third application is the differentiation between malignant gliomas and malignant lymphomas. In malignant gliomas, we can see high APT signal compared to the malignant lymphomas. And another is the discrimination between treatment-related changes and the viable tumor. After resection of the tumor, patient undergoes radiotherapy and chemotherapy. So after undergoing radiotherapy and chemotherapy, patient has to be undergone MRI to check for the recurrence. So at that time, we can use the APT-weighted sequence to check for the treatment-related changes and the viable tumors. In case of viable tumors or recurrence, high APT signal is seen. And APT can be used also in tuberculoma. Here is the case in figure 3, where it is a tuberculoma case. As we can see in APT-weighted imaging, there is a peripheral high APT signal. And higher APT signal is seen also in colloid cyst and epidermal cyst. Why? Because colloid cyst and epidermal cyst contains proteinaceous fluid. Conclusion: 3D APT can differentiate between low-grade gliomas and high-grade tumors. It can also differentiate the recurrence and the necrosis after post-treatment. In the future, APT imaging may become beneficial in pediatric tumor exam, where it can be used as an alternative to contrast and scans that are frequently used for long-term disease management. And here there are some cases which shows the colloid cyst. When we run APT-weighted sequence, we get a high signal. So this is my presentation. I am thankful for the organizing committee for giving me this opportunity to present. Thank you.
Judges, please note this candidate is crossed the time limit and extra taken 12 seconds. Judges, kindly note that, and you can go ahead with the questions. Alternatively, can be asked with the, since 4 judges are there, alternatively can be asked a question.
Hello.
Yeah, hello.
Yes, sir, I can hear you.
Yeah, Alvin, thank you for your nice presentation. Could you tell me the what is the prerequisite to run the sequence for a mite proton transfer?
A prerequisite in the sense.
It means it is possible with 1.5 Tesla machine, 0.5 Tesla machine, 3 Tesla
No, sir.
machine.
Sir, it is possible on 3T MRI. In our institute, we have totally 6 MRI. We are doing only Philips Engineer 3T. Only the 3T MRI scanners have this license, especially in Philips company. It's,
Yeah, so
the
that
license
is
not
a limitation, because 3T is not easily available in everywhere. That is a limit.
yes,
Okay,
sir.
thank you.
Prakati madam, you can go ahead with the question if you are ready.
As you said that mostly we can perform this for glioma, as I can see in your poster. Have you having any alternate protocol where we can perform this APT imaging?
Yes, ma'am. We can perform in tuberculoma cases, and we can perform in colloid cyst and epidermal cyst. In all these cases, if we perform, we can see high APT signal. Since it has protein content, we can see the high APT signal.
Okay. If we try it on for MRI breast, so it can be good for that. I'm just asking.
Ma'am, yes, ma'am. It will be good in when we try for MRI breast. Until now, the APT weighted sequence is possible only on the brain. That is on brain sequence. Till now, there is no sequence which is licensed for the body part. And till there are advancements, according to what I've read in Philips APT white paper, there are research which is going on, which we can perform the liver imaging.
Okay.
For the evaluation of HCC, that is hepatocellular carcinoma.
Okay. Good. Thank you.
Yeah, I think any question from the Partha and Raju sir?
Not from my side. It's okay.
Then we'll
Not
go
from
ahead.
my side too. You can go ahead.
Yeah, thank you, sir. Thank you so much. And thank you, Alvin. We'll go ahead with the next participant.
Thank you.
Yeah, thank you. Almelu M is from Sri Ramchandra Institute of Higher Education and Research, Chennai. They're going to talk. This candidate is going to talk about MRI gadolinium contrast media. I request the participant to upload your or share your e-poster.
Yes, sir. Good afternoon, sir. Am I audible?
Yeah, your time starts now.
A very good afternoon to one and all present in this forum. I thank the organizing committee for providing me an opportunity to present a poster on MRI gadolinium contrast media. Gadolinium is an exclusive contrast used in the radiological concern. While all other modalities use iodinated contrast media, this gadolinium is especially used in MRI. So what is this gadolinium? It is an element with an atomic number 64, and it's present in the central position of the lanthanide series in the periodical table. It is grouped as one of the rare earth metals and possesses partially filled inner shell of electrons. Next, why do we choose this gadolinium over any other metal? This gadolinium eliminates heavy metal toxicity by preventing the cellular uptake of free gadolinium, and it undergoes a process called as chelation, in which it combines with a ligand to form a coordination complex. The ligand we use here is diethylene triamine pentaacetic acid, which we commonly called as DTPA. Moving on to the mechanism of action, as we seen, it possesses partially filled inner shells. So it has 7 unpaired electrons. This causes the rapid relaxation of protons, which is the reason such that it leads to the T1 and T2 shortening. As we know, the effect of the T1 is much greater than that of T2 because we are taking post-contrast T1 weighted images only. It has a more effect on T1 images. Next, moving on to types, we have 4 different types based on the structure of the gadolinium. First is linear ionic. Example is magnivist. Linear non-ionic, omniscan. Macrocyclic ionic, dotarum, and macrocyclic non-ionic, we have gadovist. Let us see a mechanism called as paramagnetism, where it is temporarily magnetized in an external magnetic field. This gadolinium electrons possesses an externally nature of Curie paramagnetism, where it has same spin and a smaller size, in which the gyromagnetic ratio will be stronger of 657 times. So that this unbalanced spins possesses a stronger magnetic moment which no other metal can has. And this is the reason why we have an origin of bulk paramagnetism. Let's see a complication of gadolinium. It is nephrogenic systemic fibrosis. It is a fibrotic disease involving the skin and the subcutaneous tissue. This is due to the release of gadolinium from its chelates. So the patients who are having glomerular filtration rate of less than 60 ml per minute are not advised to take a contrast MRI. It is also limited to patients who are having hemodialysis. So a normal dose for an adult ranges between 0.2 to 0.6 ml per kg body weight. Moving on to the biodistribution, we have 3 different types of biodistribution. First one is extracellular fluid. As we routinely do in MRI, we will be doing it as a IV contrast, that is extracellular fluid contrast agent. Next is blood flow contrast agent. Here we will be targeting the vascular structures. For example, if a patient having infarct, we need to see the perfusion. At that time, we will be using this type of contrast agent. Next is targeted contrast agent. As the name suggests, it is particularly targeted for anatomy or pathology to be diagnosed. The extracellular fluid and the blood pool contrast agent are of positive enhancement, whereas this targeted contrast agent can either be positive enhancement or a negative enhancement. So This gadolinium proves to be a promising contrast for taking MRI scans and in diagnosis. Thank you. Thank you, sir.
Yeah, thank you, judges. Please note this candidate presented within time limit. The question is open to Partha sir and Raju sir.
It was a very good presentation, Femino.
Thank
I
you,
just
sir.
want to ask you one question.
Yes.
How do you test? Is there any test for gadolinium toxicity? Do you know about that? Anything?
No, sir. When considering MR imaging, all the metals cannot be taken into MR, whereas gadolinium is only MRI friendly imaging, so that it does not possess any toxic level also.
Okay. So, how long does it stay in our body?
Gadolinium stays for a quite longer time only, but it gets excreted.
Okay. Is there any method to excrete it faster? Is there any method procedure?
No, sir. It is a usual thing we advise for the patient to take more water.
Okay. 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 Thank you.
Thank you, sir.
Yeah.
Yes.
Hello.
Yes, sir.
Alamelu, it was a nice presentation.
Thank you, sir.
I ask you one question. You have told that for administering this kind of contrast media, that's MR contrast media, the GFR should be under 60 ml. No?
Yes, sir. Yes, sir.
So you also told us about 4 kinds of contrast media.
Yes, sir.
So which one will be more safe and why?
Sir, usually linear thing will be more safe because macrocyclic thing will be any contrast will be start breaking down. So that linear thing will be more safe.
So you are
What?
saying linear thing is safer than microcyclic.
Yes, sir.
So microcyclic is more advanced than linear, no? It is said to be. Do you think
Yes,
so?
sir.
It is the latest developed, no?
Yes, sir. Yes, sir.
Which one is the latest developed one?
Macrocyclic only. Sir.
Microcyclic only. So according to that, what you are saying, it should be more safe. Is that correct? When a product is developed recently, it should be more safe compared to the old one.
Not sure, sir.
You are not sure. Yeah. Thank you. Thank you for that answer. Okay.
Thank you, sir.
Any question from the other judges can be asked. Dhananjay sir, unmute.
Thank you for your nice presentation. I want to ask just a simple question. So here we need to link gadolinium with chelates.
Yes,
Yeah.
sir. Yes,
So
sir.
most commonly used chelates is
DTPA.
and any other chelates you know?
Meglumine, sir.
No, no, no. Why we are using DTPA as a chelates?
Because it is a safer thing, sir, to combine with gadolinium and to inject for a patient.
No, DTPA is a fast renal clearing agent.
Yes, also.
So if you link with gadolinium, it will ensure that faster elimination from body.
Yes, sir.
So if breakdown happen, then it will be challenging, na?
Yes, sir.
Okay, okay. Thank you.
Thank you, sir.
Thank you. Any question from the Pragati madam?
Nice presentation. I just want to ask, if a lactating mother, so it can be possible to give gadolinium, and what should be when by?
We can
And
give
how?
for lactating mother, and
Okay.
after the procedure, she need to take some milk outside after the procedure. Then after 2 to 3 hours, she can feed the baby. It's not an issue.
Are you sure? The 2
Yes.
to 3 hours? Okay. Okay, fine. Good.
Thank you, ma'am.
Thank you, Melu.
Yes, sir.
We'll move ahead with the next presenter. We have a next presenter, Samarpit Haldar, from IPG, MER, and SKKM Hospital. Is going to present about radiological diagnosis of stroke. I request Samarpit to share your
So it's
screen.
visual.
Yes.
Can I start?
Your time starts now.
Good morning.
Can be magnified?
Magnify. Okay.
Yeah, that's good.
It's good.
Yeah, your time starts now.
A very good evening, everyone. Myself, Shamanpita Haldar, DRD second year student from IPG, MER and SSKM Hospital, Kolkata, West Bengal. I would like to present the topic on my presentation belong about stroke imaging on the base of MRI protocols. After going through all those topics, we have to discuss what is stroke. Stroke is a neurological deficit caused by any hemorrhage or infarct. Those patients who are having stroke having a time period of 24 to 48 hours. This time period called golden hours. What is golden hours? Golden hours is a time period if the patient having a stroke, he or she can be recovered or can be treated properly within this time period. That's why it's called golden hours after any stroke. Now we have to know the pathological classification of the stroke. It's two types, ischemic and hemorrhagic. Now it comes to ischemic stroke. It's two types, artery infarct and venous infarct. Artery infarct are causes by artery blockage, rupture, mechanical compression. Symptoms are hemiplegia, monoplasia, difficult working, paralysis with weak muscles, difficulty of speaking, deviation of facial expression, etc. Maximum of the patients suffering stroke having a history of diabetes, hypertension. I would like to present some of the protocols that we should take in MRI stroke imaging, DWI or ADC. It can detect an acute infarct within minutes. The space where blood flow is void shows hyperintense on DWI and hypointense on ADC. PWI. Perfusion are typically larger than DWI lesion. The core region is totally dead and the PWI-DWI mismatch region are suggested tissue at risk. So it's very important to locate this mismatch area. Now, SWI imaging has been done to locate out if there are any chances of thrombus, which is detect hypointense. Now, the most important protocols in stroke MR angiography used 3D fast sequence. It is non-contrast angio based on flow-related enhancement. Flowing blood much brighter and stationary tissue is subtest by multiple RF pulse. So we can easily point out the path where infarct or hemorrhage has taken place. GRE sequence detect the paramagnetic effect of the breakdown products of hemoglobin. Now it comes to venous infarct. It occurs due to obstruction of the venous system by thrombus and external compression. External compression symptoms are headache, visual blurring. Maximum patient who suffering this infarct are young female patient with OCP history. Sequences are DWI, SWI or SWAN, T1, T2 flare, thrombus. Thrombus looks bright, venogram, PWI, 3D ASL. Now it comes to hemorrhage. Hemorrhage is release of blood from a broken blood vessels causes by head injury, rupture of aneurysm, etc. Maximum middle-aged young patient comes to several symptoms such as sudden serve headache, double vision, nausea or vomiting, abnormal heart rhythm, etc. The sequences are T1FS, DWI, T1, T2 flare, GRE, PDFS with a thin card, 3D TOF MRA, 3D phase contrast MRA. Thank you.
Thank you. The question is open with the judges. Raju sir can start.
Okay. Uh, okay, Samrit Khalder. It was a nice
Yes, sir.
presentation.
Shamolpita Haldar.
Some
Shamolpita Haldar.
Samoprita Haldar. Okay,
Shamolpita
okay.
Haldar, yes, sir.
You are from Bengal only?
I have Bengal, West Bengal. I'm from West Bengal, SSKM Hospital,
Okay, okay, okay.
Kolkata.
So basically, the modern science of managing stroke deals with one thing. That's how much cells you can save after the stroke has occurred. Do you heard about that?
Sir, in PWI, these core cells are fully dead, but these cells are can recovered. These penumbra cells
So
are
yeah,
recovered.
that's called penumbra. Okay.
Penumbra cells are can recovered
So
if it's within time.
yeah, so I agree with your presentation, but in modern scientific therapy of stroke, actually an mixture of MRI with MDCT is applied in such cases, basically.
Yes, sir. MDCT.
So you will be knowing about that. Your institute has an MDCT along with the 30 MRI. Or
Sorry,
you are
sir?
no, have you seen any management of these cases directly? That's what my question is. Have you seen direct management? No.
No, sir.
No, that's okay. That's okay. So basically, these two things. One is MRI along with MDCT is usually applied in fresh stroke cases. So the basic principle is this: what you said, the saving the penumbra. That means how much cells can be saved in the coming hours by applying the right kind of therapy, and MRI helps it. It is the basic things which the basic principle we are applying in the management of stroke in today's management. Okay.
Okay.
So I was just having a comment on that. Thank you for your nice presentation. Okay.
Thank you.
Hello, Shamarpita. It is a very excellent presentation.
Thank you, sir.
I just want to ask you one thing.
Yes, sir.
With MRI and CT, with both we can see the stroke. So, why the MRI you think more better than CT?
Sir, MRI imaging is distinguish past strokes from recent stroke. Mainly diffusion MRI should be considered more useful than CT scan for distinguish acute ischemic stroke within 12 hours for presence of fast stroke symptom.
Okay. For acute stroke, you are saying.
Acute stroke, huh? Yes.
So can MRI detect the old strokes?
Yes, sir. Usually, silent stroke is noticed.
Okay. Thank you.
Thank you, sir.
No question from my side.
Samarpita, first of all, I would like to comment on your poster. It is very beautifully you detailed everything. Even
thank you, ma'am.
Yes, even can a layman, if you explain, he can understand. And I just want to know if a patient is in worst condition, what will be your prefer, CT or MR? Very basic question.
Sorry, ma'am. एक बार और फिर से once
Okay.
again.
Yeah. If there any emergency, what will you prefer, CT or MRI for a stroke patient?
First, I chose CT.
Okay.
Then MRI.
Okay, and in MRI
after 6 hours, then MRI.
Okay, and in MRI, which sequences will you prefer?
In MRI, first to DWI or ADC, then PWI, Then MRA, SWI, GRE.
GR, yes, yes. Okay, good. Well done.
Thank you, ma'am.
Thank you so much. We'll go ahead with the next presenter. Samarpita, can you end your sharing screen? Thank you. Next presenter, we have Samiksha U. Gonkar from the Goa Medical College. He's going to talk about diffusion tensor imaging and fiber spectrography. I request you to share your screen. Samiksha?
Hello, sir.
Yeah.
Is my screen visible?
Yes, visible. Your time starts now.
Okay, sir. Good evening, everyone. Myself, Samiksha Gaonkar from Goa Medical College. My topic for e-poster is diffusion tensor imaging and fiber tractography. Diffusion tensor imaging was introduced by Sir Peter Basir in 1994. It is an MRI technique that uses anisotropic diffusion to estimate the axonal organization of the brain. And fiber tractography is a 3D reconstruction technique to assess neural tract using data collected by diffusion tensor imaging. The principle of diffusion imaging is based on the measurement of thermo-Brownian motion of water molecule. In DTI, anisotropic diffusion is used to generate contrast. Tensor is a mathematical model which represents the direction of anisotropic diffusion. So a tensor, which is a 3 by 3 symmetric matrix, is used to produce a 3D ellipsoid. This ellipsoid represents average diffusion distance in each direction. And the properties of ellipsoid can be defined by 6 parameters. Those are 3 eigenvectors and 3 eigenvalues. So the eigenvectors are the vectors which represent the major and the minor axis of diffusion ellipsoid, and eigenvalues are the ADC values of the tensor along the direction of each eigenvector. DTI sequence. The DTI sequence is similar to diffusion weighted imaging sequence, that is PIN-EPI. The only difference is that diffusion gradient is applied at least in 6 directions. Using DTI information, different maps are generated. So the first and the most important is fractional anisotropy. It measures the degree of anisotropic diffusion in each voxel. Next one is mean diffusivity. It is a measure of directionally averaged magnitude of diffusion. The next is axial diffusivity. It is apparent diffusion parallel to white matter tract. And the radial diffusivity, which is apparent diffusion perpendicular to white matter tract. The next one is a color-coded map. In this, specific color are allotted depending on the direction of the diffusion. For example, red color indicates right to left, green is for anterior to posterior, and blue is for cranial to caudal. Fiber tractography. It is a technique used to assess direction of white matter tract within the brain. So this technique produces a three-dimensional colored image of the white matter. Clinical application, the most important is the assessment of deformation of white matter by tumors, then pre-surgical planning, and early detection of Alzheimer's disease, schizophrenia, and multiple sclerosis. Some advantages of DTI is that it contributes in evaluation of almost invisible disease or occult regions in normal appearing tissue, and it provides 3D visualization of neuronal pathways. Some limitations are the technique cannot differentiate when 2 or more fibers are present within one voxel. It is sensitive to motion, and it requires extensive computing power and expertise. Some advancements are diffusion spectrum imaging, diffusion kurtosis, and high angular resolution diffusion imaging. That's all. Thank you very much.
Thank you so much. The question is open to all the judges.
Hi, Samiksha. I have presented a nice one. Nice topic. Very good presentation. I just want to, I have shown that you have mentioned that fractional anisotropy.
Yes, sir.
So, can you tell me the value of that fractional isotropy?
So value of
What is actually, tell me, what is fractional anisotropy?
so fractional anisotropy, it measures the degree of anisotropic diffusion in each voxel.
Okay, but what is the value? It's a scalar value. So then which lies in
So it
between.
ranges from 0 to 1, and 0 is for isotropic and 1 is for anisotropic. For example, CSF, it is 0.
Okay, well done. Thank you.
Thank you, sir.
No question from my side.
I also have no questions.
Thank you so much. Any question from the other judges? No. Okay. Thank you, Samiksha. We will go ahead with the next presenter. Just please note, this candidate also presented within a time limit. The next presenter we have P. Ruby from Savita College of Allied Health Sciences, Chennai. We're going to talk in the topic of gadolinium retention is a gadolinium deposit on brain tissue. I request candidate to share the PPT.
May I audible, sir? Am I audible, sir?
Yes, yes, yes. Can you make it full screen?
Okay, sir.
Full screen.
Shall I start, sir?
Yeah, okay. If it is possible, a little zoom option available.
No, sir.
Okay, go
Okay,
ahead.
sir.
Your time starts now.
Good evening to all. I'm Ruby from Savita College of Allied Health in Chennai. I'm going to present about gadolinium retention. Is gadolinium deposits on brain tissue? Let's see. Gadolinium is a rare earth metal element from the lanthanide series. Atomic number is 64. It is highly toxic because it is unbounded state. Then why we use gadolinium? It has a powerful paramagnetic properties. It having 7 unpaired electrons perturb proton relaxation in water, resulting in a shortened T1 relaxation time, and it enhances the tissue contrast. Example, tumor. In 1988, the first contrast study was done. The FDA considered gadolinium as safer, but allotted many regulations because of NSF, which means nephrogenic systemic fibrosis, allergy, burning, and even cardiac arrest in patients with renal dysfunction. Based on a ligand type, it classified into linear type and macrocyclic type. In linear type, have an elongated organic molecular ligament that wrap around the ion. And that means gadolinium's one side is binded with the other elements, one side is completely free. Example, gadobendate dimeclamine, gadodiamide. In macrocyclic type, form a cage-like ligament structure with the ion trapped in a performed central cavity. It's like a shell. Gadolinium is in center. The other elements are binded with surrounding the gadolinium. Example, gadobutyrol. Then transmetallation reaction. The displacement of gadolinium from its halation site occur at least in part via the so-called transmetallation reaction. It usually occur in linear type because one side of the gadolinium side is completely free. So the gadolinium displacement will occur there. Lymphatic system. We already know that if we give contrast, the contrast flow through the blood vessels and excreted by the kidney. But the fact is also the contrast goes to the CSF itself. The subarachnoid CSF recirculates into the brain parenchyma along paravascular spaces and exchanges with the ISF, interstitial fluid. On post-contrast flare image, the region showed higher signal intensity because the contrast will stay in CSF for a longer time, but the gadolinium half-life is 1.5 hours. After that, the displacement of gadolinium from its lesion site occurs. Then ion traffic mechanism. For neurodegenerative disorder patients have a brain gray matter structure, ion-rich content. So the gadolinium binds with ion and the gadolinium deposits. In 2004, GP et al. Found gadolinium deposition in patients who underwent hip replacement with the help of plasma atomic emission spectroscopy, he concludes in statement that the gadolinium deposits on the bone marrow itself, so bone as a kit. In 2010, FDA agreed the state and recommended not to use Magist, Omnis, and Optima in patients with AR or chronic kidney disease. In 2013, Canada et al. Found gadolinium retention in patients with normal renal function. Later, many researchers agreed that too. In 2017, FDA identified no harmful effects to date with the gadolinium retention, but deposited gadolinium have some consequences which is unknown. In that time, one person raises a case against this MRI studies because her wife undergone and made MRI frequent contrast cases. Chelation therapy is useful for her. Chelator like PTPA used to bind gadolinium remaining in the body for, and she claimed this treatment by recovered. Linear versus macrocyclic. Many researchers found that deposited gadolinium is higher in linear type than macrocyclic. Why it is? The molecular structure is different from that of. Then in 2018, new safety measures should be followed. Limit the dose as low as possible. Use macrocyclic because low retention than linear. The date of last MRI with the gadolinium, frequency of episodes. Conclusion. Many researchers and FDA conclude that deposition of gadolinium in body is completely true, but the actual mechanism is still unknown. Aware about the unknown consequences and limit or consider about the previous episodes of contrast. Thank you, sir.
Thank you, Ruby. It was very nice presentation. I just want to ask you one question. Other than brain, where the gadolinium can stay? Other than brain.
Sorry, sir.
Other than brain, where the gadolinium can stay in our body?
Sorry, sir. I'm not audible.
I asked you, other than brain, where the gadolinium can stay in our body?
Other than brain, kidneys, sir.
Yes.
Kidneys.
Okay, then any other thing?
No ideas.
Okay. It can stay extracranial also, like liver, skin, and bone also it can stay.
Yes, bone also, sir.
Okay. Thank you very much.
Thank you, sir.
Okay, Ruby. Hello.
Yes, sir.
Hello, Ruby.
Yes, sir.
Yeah, it was a very relevant presentation just by the topic you picked, because we are daily using gadolinium in MRI studies,
Yes,
and newer and newer risk about gadolinium is finding out. That's what you said, no? In 2004, the bone marrow intervention is found out. In 2013, renal function problems are found out, and in 2017, renal effects again found out. So my question is a very simple question. When using gadolinium, you said the brain will retain it for only 1.5 hours.
Not like that, sir. Gadolinium's half-life is 1.5 hours, sir.
Hours. What does that mean?
After that, the gadolinium displaced from its chelation site, sir.
Okay, but still it can remain in the brain itself.
Yes, sir.
After that also. So
it will create a high-risk toxicity, sir.
Yeah. So what kind of toxicity it can cause? Is there any findings? I'm just asking, is there any findings?
Nephrogenic systemic fibrosis.
Yeah, it's about what you are saying. I am asking about brain.
Brain, sir.
Yeah. You told me the half-life period is 1.5 hours.
1.5.
Still it can retain in the brain. What kind of chemical effects can it cause after 1.5 hours? whatever it remains in the brain. Is there any findings about that study? No, you are not sure about that.
Sure.
So you just referred it can remain in the brain for more time, but you are not sure about what it can cause when it is in the brain for more time. Is that okay? No, this is a new subject, so don't worry about
Yes,
that.
sir.
If you have read that thing or if referred that thing, just say. So you haven't referred that thing.
Okay, sir. I will try.
Okay. Thank you.
Thank you,
Don't
sir.
worry about it now.
Okay, sir.
Hello, Ruby.
Yes, sir.
Presentation, and I was just looking for in your present. You have said that during presentation, macrocyclic based gadolinium contrast is better. Why? Than linear.
Yes, sir.
Why it is better?
Sorry, sir.
Why macrocyclic based gadolinium contrast is better than linear?
Because the displacement of gadolinium from chelation is a little different, sir, for macrocyclic. In linear type, that is easy to displacement of gadolinium from chelation, sir.
Okay. So, do you think why macrocyclic is better? Because in macrocyclic, gadolinium binds much more strongly than linear. So,
Yes,
it is
sir.
not possible to get dislodged inside the cell or inside the body.
Okay.
So, we can that way reduce the gadolinium toxicity. Okay.
Okay, sir.
Pragati madam, any questions? You can go ahead.
First of all, Ruby, you presented very
Yes,
well.
sir.
Okay.
Thank you, ma'am.
I want to ask very basic and simple question.
Okay,
Is
ma'am.
gadolinium can cross blood-brain barrier? Very basic question. Logical. Do you know? BBB?
Yes,
Blood.
ma'am. Blood-brain barrier.
Yeah. Just logical. What do you think?
Yes. Yes.
Okay.
Good.
Good.
Thank you.
Can I ask one more question? Why we need gadolinium for scanning?
Sorry, sir.
Why we need the gadolinium for MRI scanning? Why?
To see the blood vessels and also.
That is the reason.
That's also.
Very basic question. Okay, think over that. Because this is the simplest question. Why we need anything? Something positive has to come out. Something you have mentioned something. You reduce that T1
Yes, sir.
time also. And what else apart from this? How it is reduced?
Okay.
Anyway, thank you. Go and look on this. Okay,
sir.
thank you.
Thank you, sir.
Thank you so much for the all the contestant for the wonderful presentation. Here with this, we are ending today's e-poster presentation. Yeah, thank you so much. Before I ending with the thank note, I want to announce the last week e-poster presentation winners. The last week was the topic was computed tomography. The first prize goes to Raki S. Nayak, Kesagada Medical Academy, Mangalore. And the second prize goes to Gautam Raj from Nimans, Bangalore. So I congratulate both the participant and winning the prizes in the category of computed tomography. And I like to announce that all the participants will receive a 3 set of books related to radiological books from the JBD publications from the Jaipur. Anyway, those related issues will be communicated later. And as we mentioned, all the participants will receive certificate, medal, and cash prize. Those information will be given later. With this, before I thank, there are certain list is ready with us announcing the quiz winners that will be shared in the group. It will be shared in the group. With that, I will. Antu sir, are you there? No. Okay. With this, I'll thank all the judges, especially Dr. Dhananjay Kumar Singh, Rajiv Krishnan sir, Parthu Jyoti Das, and Pragati Sahu madam for your valuable time. And I knew that despite of Sunday, you are agreed to be a judges of the program.
Thank you, sir.
You
Thank you
loved it.
for
And,
opportunity.
yes. If I request all the judges to give small tips to the students. You've seen that since morning staff presentation, and then after that e-poster presentation was there. I request from Rajesh Krishnan sir to start. Sir, can you unmute?
Hello. Am I audible?
Yes,
Hello.
yes, sir. Please go ahead.
Yeah,
Yes.
yeah. Whatever I have seen from this presentation right now presented, the students have picked up very, very different topics on MRI. But my suggestion to them is that if they can practically approach these subjects, that means there is some practical approach and a theoretical approach. So if your institute permits that kind of a practical approach in your department, take such subjects. For example, whatever I am, the Ruby presented this gadolinium retention in body. It's a very relevant topic compared to some other topics, completely theoretical. So as students, you may have limitations, but if it is possible, try to make cooperation from your department staff also and take up practical type of papers so that it will be easily conveyed. That's one of my suggestions. Thank you, Shashi. Hello.
Yeah, Dhananjay sir, please go ahead.
Yeah. See, once I was a student at that time, and if I compare with present students, the way they have presented nicely and a very advanced topic, it's really very. I'm very much happy, and that is good that undergraduate students are taking in deep interest and advance on presenting on advanced topic. That is very good for our community, and I'm very hopeful that things will change positive way and will be much more talented. Our new breed will be coming very soon, and we'll be happy that our new age of technologies will have a good exposure of theoretical as well as practical knowledge. And I completely agree with Rajiv sir that they should think on practical issue also. This will give much more confidence. Thank you.
Yeah, Pragati madam, and followed by
Um, Even I just passed out last 3 years back, and I know students, your situation, your condition, but I'll agree with Rajiv sir. Just go with, first of all, clear your basic. If you're preparing any poster or presentation, just go with little bit detail. Then it is not need to put so many things in a poster and thing, and you're not having any idea. Prepare very basic and simple, and try to just learn and explain in easy way. That only I learn and I can suggest. And I'm so fortunate that ISRT given me such a big opportunity to judge, and with these great peoples with me. Thank you once again and good luck. Thank you.
yeah, Partha sir.
Hello everyone. It was very nice session. I'd like to congratulate everyone, every participants. They have presented nice topics. Only thing is that it was little advanced topic, so it is good that our standard is a little going up. So yeah, people have done very good job. Well done. Best of luck for your future. Just my suggestion will be you worked so hard. Hard work is good, but smart work is more good than the hard work. So do smart work rather than hard work. Thank you, everyone. Thank you, ISRT, for giving me this opportunity. Thank you, everyone.
Thank you so much. With this, we will end the today's session, and I'll just share a few of the quiz results are ready. I will just share this thing, and the students can be watched through this YouTube. This is from the West Bengal, and this is from the Odisha, and this is from the Kerala, and this is from the Bihar, this is from the Tamil Nadu, this is from the Punjab, this is from the Uttarakhand, and this is from the Karnataka. There are one more list supposed to be ready. I think it will take little time. I will be shared that information in the Google WhatsApp group and also in the Telegram group. Thank you so much for your time. Thank you, judges, and thank you all the participant, oral presenter, especially oral presenter staffs category, and also e-poster presenter. Thank you so much. See you some other day.
Thank you, Sasji. You are the pillar of this event, and I know your devotion much more than us. So thank you very much.
And again, congrats, Sashi, for conducting such and coordinating such a program. Is not easy. It's very difficult. From your part, you have put the maximum, and I thank you for that from the side of ISRT also.
Thank you, sir. Thank you so much. I should just thank to the ISRT because they trusted me. For that reason, I should say that. Thank you.
Thank you.
Thank you. See you some other day. Thank
Bye.
you so much. With this, I will ending the today's session. Bye.